Yes, I'm recording the class. So you have to maintain the patient NPO. That's correct. And there's no heat on the abdomen. You don't put anything hot on the abdomen because you don't know what is affected. What do you assess the patient for? So if the patient presents to you and say, I have abdominal pain and blah, 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 I have a fever, what assessment will you do?
Focus assessment.
So this is another thing I'm gonna hit on it. Head to toe assessment is good. That's complete assessment. But remember, in the case of NCLEX, mostly what they want you to do is focus assessment because they are focusing on a particular condition in that question. You understand? Unless they tell you to assess the patient head to toe, like a scenario, they give you a case scenario or case study to go over. But the focus of NCLEX is they always describe a particular problem in a patient, and that is a focus assessment. So if the patient presents to you with abdominal pain, first of all, in the NCLEX, you're going to look for answers that are related to assessment or assessing the patient's abdomen. So if you say abdominal pain, the first thing I'm going to do, I'm going to palpate your stomach to see if it's tender. You use the nursing process. So you have been presented with a condition, then you start with the nursing diagnosis. So if your problem is abdominal pain, I start by touching your stomach to feel it. Ask for diarrhea, ask for nausea, vomiting. So those symptoms, NCLEX will put it together. When they're asking you for a general management, IV therapy is good. Maintaining NPO, having nothing go into the patient's stomach is the best option to do. And no heat on the stomach. The patient can tell you, I just feel like I need an ice pack on my stomach. So you also want to assess for abdominal distension. Okay, abdominal distension. So patients that have liver problems, they will also have abdominal distension, like the cirrhosis ones. But with them, another thing you will see, especially if it's advanced, is the yellow skin color. So sometimes you don't have to look on their sclera to see that they are yellow. Their generalized body appearance will show you that are yellow. I'm going to give you this one, Asperger's syndrome. What is Asperger's syndrome? And this syndrome is a form of what? What is it? Asperger's. You want me to spell it? I don't.
Yes.
My pronunciation is sometimes bad, but it's ASPERGRS. GR and then apostrophe and S. Syndrome.
I didn't get the spelling.
ASPGER.S. Asperger's syndrome. Apostrophe S. Or Asperger's syndrome. Okay, it's a form of autism. Okay, it's a form of autism.
Oh, yeah. Okay.
Yeah. So if NCLEX mentioned that a mother brings a child to the hospital and the child has been diagnosed as Asperger's, you want to take note that that's autism. So any management you are going to think of giving to an autism patient, you want to start thinking towards that side. Okay?
Okay.
Now the next one is the treatment focuses on improving communication or the client's social skills. You know that patients with autism, their problem is relation. They look at you and sometimes you appear as a scary thing to them. They feel threatened by your presence. So it's social relation and communication, and sometimes they have problem communicating. They are not able to answer questions right, especially if they are not in their right senses at this moment. They will not communicate properly. Now we'll talk of asthma and then we move on because I know we just did it the last time. So asthma is an obstructive airway disease caused by what? What is caused by?
Yeah, so the asthma triggers.
You say?
They could cover the asthma triggers, spread danders, and those stuff.
Yeah, but to know what exactly it is caused by spasms and inflammation of the bronchioles. That if I ask you what is asthma, it's an obstructive airway that is caused by spasms and inflammation of the bronchioles. So you look at the respiratory system and you get the bronchioles. The inflammation of the bronchioles will give you asthma. And what are the signs of asthma? This is where you now
Wheezing.
Wheezing, yes. Good.
Difficulty breathing.
Difficulty breathing,
Labored breathing.
Labored respirations. That's the same. Anyway, it can be different at a point. Then we have expiratory wheezing and possibly a cough. The patient can have a cough as well.
Sometimes we have chest pain.
Chest pain, shortness of breath. Okay, so when will the client experience the cough? If a patient is asthmatic, when will they normally experience a cough?
On inspiration.
Pardon?
On inspiration, like trying to breathe in air.
Trying to breathe?
Yeah, when they're trying to breathe in.
I know. When? What time of the day will they normally experience the cough? At night?
In the morning.
Mostly it's at night. Asthmatics experience severe cough at night, not in the morning.
Why at night?
So when you go to sleep, that's when your whole body is relaxed and there's irritation. So remember, when you put your head down in between your bronchioles, the opening, they are irritated because you have free flow, you are relaxed. So nothing actually distracts your thinking. Is my video on or no? Okay. Nothing actually distracts your thinking. So because nothing actually distracts you, it initiates the cough reflex. So the cough reflex is initiated or irritated. Yes, it's irritated, and then you cough more at night. Okay. Does it make sense?
Yes.
Yeah. So, and what is the primary treatment goal for asthmatics? Patients that have asthma, what is our primary goal for treatment?
Clear the airways.
Pardon?
Clear the airways.
Yes. So the primary goal is to clear the airway and have them breathe freely. But remember, is to identify the irritating cause. You also want to be able to identify what is causing it, causing the patient to have that. And what medication work best for treatment? I didn't go into the respiratory medications yet. I have them. I'm going to run over them.
Bronchodilators.
Bronchodilators, steroids.
Corticosteroids.
Corticosteroid, anti-inflammatories, metered-dose inhalers, and leukotriene modifiers. Those ones help with.
So always you give the bronchodilators before any other medication.
Yes, you give the bronchodilators and then you give. But if it is in the home management, you want to give the patient the inhalers. So they do the leukotriene modifiers and then the metered-dose inhalers. They can use that at home as stable treatment because they also open the airway. But if it's in the hospital settings that the patient presents with acute attack, you want to start with the bronchodilators and then you move to the steroids. So bronchodilators to steroids, and then you can go into a heavier treatment like magnesium sulfate that we talked about the last time. So I just intentionally put this diagram here to show you the bronchioles. So since asthma is inflammation and spasms of the bronchioles, these are the bronchioles. So if these ones are spasming and they are inflamed, This is where it's gonna be. So the whole of this ones, this small pointed stuff are the bronchioles. So spasming, if they are spasming, that means air is not able to move freely. That's where you now start hearing the wheezing. So something is irritating them. So they are all kicking each other. They are all trying to move and they are shaking like this. So they all keep dangling all around and then it's squeezing on each other. That's where you hear all of that wheezing. So what are leukotriene modifiers? I just mentioned them. What do you think they are?
The long-acting bronchodilator.
Long-acting, but what are they? What are they? They are drugs that are used to block the chemical leukotriene, which reduces inflammation. They help to reduce inflammation in the bronchioles. So the secretion of leukotriene. So they block the chemicals. And I think pretty much that's it. Okay. I may not, because of the time, I may not be able to go into central nervous system, but I'm going to ask you a question. Bell's palsy. So Bell's palsy will always affect which cranial nerve?
7.
I don't know if we have studied that yet, but it always
Cranial nerve
affects
7.
cranial nerve 7. Yes. I think I had prepared something under the cranial nerves. I just don't know where I put it yet, but I'll get it. What does a client with Bell's palsy suffer from? What do they suffer from?
Movement issues.
You say?
Like weakness in the muscles on one half of the face. The facial nerve.
The facial nerve is affected, you know. But my question is, so if I present to you, what will I tell you that will make you suspect that this can be Bell's palsy and not a stroke? Because remember, it can look more like a stroke. If you remember the stroke symptoms. So the patient will tell you, okay, I have this severe headache on this side of my head. Oh, you can't see me, right?
Yeah.
Now we can see you.
Oh, okay. So the patient is going to describe the headache to you. Most often, some of them will say on the right. And then when I talk, my mouth goes to the left side. So my headache is more to this side, and this side, I feel so numb. And when they talk, their mouth go on the opposite side. So there'll be temporal facial paralysis that affect chewing, eating, and closing the eye. So the patient tells you, okay, my husband came back from work and told me that I was sleeping and my one eye was completely closed and the other eye was not able to close. And when I wake up, I was putting my makeup and I realized that when I try to talk, my mouth is not moving right. It's moving to one side. And I feel numb on this side, but my mouth was moving on this side. Then you want to suspect that. So they have problem chewing, eating. They feel like it's not coordinated. You are chopping and your mouth is not, your teeth are not able to collaboratively chew the food. So what is the treatment for Bell's palsy? If I suffer from Bell's palsy, what is the best treatment for that?
Maybe physical therapy.
Physical therapy, yes. So you want to use artificial tears. You want to wear an eye patch at night, wear glasses to protect the eyes, and steroids to reduce edema or swelling in the face. Basically, that's the treatment for that. So can we continue with our?
Can you go over the treatment again?
Yes, you wear an eye patch at night. You use artificial tears. You wear glasses to protect the eye and steroid to reduce edema or swelling. Okay.
All right.
And I had mentioned the the meter dose inhaler. Let's go back to it. So if NCLEX give you the steps of administering a meter dose inhaler and they ask you to arrange them, do we know the steps to administer a meter dose inhaler?
You exhale. You exhale as much as you can.
So if I have this, and then if I have this, Clementina is the patient, how will you educate Clementina to use this at home? That's the question I'm asking. So this is a meter dose inhaler. I just took it from the medication box and I'm handing it over to the patient. But this is the first time the patient is sending it home. How will I tell Clementina, or how will I tell the patient to use it?
What I know, you exhale, you pick it up, you exhale, then you put it on your mouth, then you put the medication inside. Then
I know it's hard. It's harder if you have not seen the steps to arrange them. Probably if you have seen the steps to arrange. Let me give you the steps so that you arrange it. Okay?
Okay.
I'm going to give you the steps. I'm not arranging them. I'm mixing them up for you. I want you to arrange them. Step number 1. Breathe out away from your inhaler. Number 2, bring the inhaler to your mouth and place it in between your teeth and close your mouth tight on it. You can shorten that if you want, something that will make you understand what it is. Bring it closer to your mouth, put it in between your teeth and press lip it. You close your mouth towards it. Number 4, shake the inhaler.
Number 3.
You didn't give us 3 yet.
Oh, okay. So number 3, shake the inhaler well before use. Number 4, start to breathe in slowly. Press the top of the inhaler and keep breathing in slowly until you have taken a full breath. 3 to 5 seconds. Should I repeat that?
No. So it's 1, 3, 4.
It's 3.
3, 2.
Wait, I haven't finished.
Uh-oh.
I have 2 more. Sorry. I'm going to give you 6 options. NCLEX standard. These things I'm giving you are standard NCLEX stuff. I just didn't put it down. I have everything planned out and written out. It's just not in a soft copy. So the 5th one is remove the inhaler from your mouth and hold your breath for about 10 seconds, then breathe out. And the last option is remove the cap.
Remove the what?
Remove the cap, C-A-P.
Okay.
Remove the cap on the inhaler. So if you have to teach me as your patient, how will you arrange these steps? How will you make me understand how to use it? Because I'm going to use it at home. There's no nurse to do it for me. So it's just me and myself trying to take care of my asthma at home. So how will you teach me to use the inhaler?
First, you would exhale out, shake the inhaler. Wait, actually, I didn't hear the last one. Well, you would open the inhaler.
The last one is to remove the cap.
Remove the top, okay.
Mm-hmm.
So after you remove the top, no, you shake it, then you remove the top, you exhale, then you put the inhaler in your mouth, then you
Wait, I'm getting confused with the options. Let me come. I don't think I have a pen here. I'm interested in it, you know. I just
you can write on this board, but I don't know how to write on the board. There's a way you can write on this board.
Is there? Yeah.
The way you can write on this board.
In the chat room.
Yeah.
Yeah, let me see. So I'm going to write it down. Simone, one, you said.
Shake it first.
Oh, we all want to write our steps in the chat room.
Okay, that's fine.
But that will take time, right? I want us to move fast. Huh?
Let's go.
That will take time. Let's just discuss it. I don't want us to waste too much time on this. Okay, the first one is what?
You shake.
Shake it.
You shake it?
Shake the inhaler well.
Mm-hmm. And the second one?
Take off the cap.
Exhale.
Remove the cap.
So you remove the cap first, and then you shake it.
Yeah.
Okay? If the patient finish shaking it, and it's coming back to remove the cap and forget and put it in the mouth, it's not going to help. So the first one is to remove the cap, and then you shake it well. Number 3.
Exhale.
Number 3, exhale. Number 3 is
Then
to breathe out and away from your inhaler.
Breathe out. Right.
Number 4.
Then you put the inhaler in your mouth and tightly have your mouth around it.
Okay, good. Number 5 is level 5.
And you administer.
Yes. So you start to breathe in slowly. So you tell the patient. So once you press the thing, you start to breathe in slowly. Okay, and then you press on the top of the inhaler and hold it for how many seconds? And hold your breath for how many seconds?
10 seconds.
3 to 5.
3 to 5 seconds. So when the patient press one puff, they hold your breath for 3 to 5 seconds. Okay, before you breathe in and out. Then the 6th one is to remove the inhaler from your mouth. Hold your breath for about 10 seconds, then breathe out. That's after you are done. Okay. So if I have 3 different or 2 different inhalers to use, how much time do I use in between each of them? Between 5 minutes. Okay. Okay, so now today we are going to start with influenza, right? We finished coronavirus the last time. I remember I was telling you about the monoclonal antibodies before we left. Now influenza is also called the flu, and it's a yearly and a seasonal disease. So it's highly contagious and acute. Can we see my screen? Yeah. So influenza is highly contagious, acute viral respiratory infection, and it may be caused by a virus known as type A, B, and C. So it needs yearly vaccination, which is recommended to prevent the disease. So everybody suffering from flu has to take a yearly vaccine. We have the avian flu, which is the H5N1, and this one you can get it after birds. It affects birds. It does not usually affect humans, so we are not worried about it. But they tell you, however, human cases have been reported in some countries. An H5N1 vaccine has been developed for use if a pandemic virus were to emerge. So if it affects birds, why then do they identify it in humans? Now, this is what happened. So NCLEX is going to give you an example of an area where they eat birds, and those birds have been affected by the avian influenza. So they give you a scenario containing a particular location that the patient is coming from. The patient tells you the last thing I ate was a bird. You understand? And then you come to see the symptoms. They want to talk about flu. So mostly, even though some cases have been reported in human beings, it means if you are a human being, you would have to have eaten something, or something about the bird that is infected with that virus would have entered into your body for you to get it. So it's not a virus that should be in humans. It's supposed to be birds. but people get it because they get in contact with these viruses. That's one thing we're yet to understand, how the coronavirus was started. And people kept saying people are eating bats, people are eating bats. They've been eating bats for years. I don't remember if I was a child, I've eaten a bat before, but maybe I've ever done it because I remember my area, they eat bats. So eating bats is not necessarily what would bring you the COVID, but they already had the COVID before. So it's a virus that resides in some animals, but people eat it and they get it. Now the swine flu, I remember this one, they usually say it was in the pigs. It's a strain of flu that consists of genetic material from swine, avian, and human influenza viruses. So the symptoms are those that present with seasonal flu, and additional vomiting and diarrhea commonly occurs. Now, this is just to add for the sake of the NCLEX. The flu every year has a different strain. So if you have ever taken flu vaccine, you will realize that some of the years you get the vaccine and you feel a different side effect of it. Other years you get it and you don't feel anything. Last year when I got a flu shot, I was knocked out. It was very painful. There was tenderness to the side. But here's the thing, every year the flu vaccine comes with a different strain. I remember Simone had asked a question. I said I was going to research into that. So I went on the CDC website. I checked, and then I also went on another site to do a research on that. So I realized that every year the vaccine that we get are of different type because the virus that come each year are different strains. Thank God they have most of those vaccines that are able to combat that. So if they get the virus that will be combating COVID vaccine, will not have a problem like this. So the flu, nobody hears of it because if a different virus of it comes, they get a vaccine for it. But the COVID, they haven't been able to get a specific vaccine yet. That's why we are all struggling now. So the signs and symptoms of flu will be acute onset of fever, muscle aches, headache, fatigue, anorexia, sore throat, cough, and rhinorrhea. That's this thing. So if you want to teach the patient under this, you want to teach the patient to avoid person-to-person contact. People that are having the virus, you should not get in contact with them. You want to give them space. So that's mostly the preventative method for the flu. Hand washing is always constant. So NCLEX is going to present with you the signs and symptoms, and mostly they can tell you sore throat, cough, anorexia, fatigue. Anorexia is more also of abdominal, so they may kick it out, but they just describe the symptoms, and then they let you know where the patient have been. So the patient has taken an avian, I don't know which location is that particular thing, but it looks like it's mostly in the tropical area. So they're going to tell you in the cold areas like America, or the patient has been to South America and came back with those symptoms. Now they want you to figure out what you will do for the patient first. So if you realize it's a flu, you want to think of isolating the patient first. If they want to know about the precaution to take, it's going to be droplet. Okay, droplet and contact for the flu. So, but mostly they'll use droplet for that. Legionnaire disease is acute bacterial infection caused by Legionella pneumophila. The source of the organism include contaminated air conditioner. Oh, I think I passed here, right? I remember Simone asked a question about this.
Need to isolate a patient with influenza, give up the person a separate room.
You say?
Is there need to isolate the person with influenza?
Yeah.
Like give the person a separate room?
Yes. Yes. You have to isolate. But if they have others that are respiratory, airborne, you want to isolate that one faster than this one. Okay? Because this one is droplet and contact. Now, signs and symptoms of influenza, of Legionnaires' disease. I think I treated this one. Are we here? I remember I did this one because I remember Simone asked a question about the water. treatment methods and how we can still get this disease. So I'm going to jump that. Should I? Clementine?
Don't jump.
Okay. So
I was half awake, half
yeah. So I'm going to send this document to you guys though. I will send it for you to go over it. So the source of this bacteria is from contaminated water, air conditioner, cooling system, and warm, stagnant water supplies, including water vaporizers, water sanitizers, whirlpools, spas, and showers. So it's a person to person. In this case, it does not have to be a person-to-person contact, and the risk for infection is increased by the presence of other conditions. So if you already have symptoms of flu and you got in contact with this virus, or this bacteria, the risk is higher for you to get it. So it's mostly found in water bodies, like I said the last time, throughout the pipelines. So Simone had asked how about the water treatment they do. They treat the water all right, but remember the way the water is going to, we have a water body right by my house. The time the water travels through the pipelines to this house, they are not able to treat the pipelines individually, and through the showers, those things, and air condition, the cooling system that produce heat and warmth at the same time, those things will cause this virus to function well. So the signs and symptoms will be influenza-like, to just be like the flu with a high fever. So chills, muscle aches, and headaches that may progress to dry cough, pleurisy, and sometimes diarrhea. The intervention is supportive treatment, and antibiotics may be prescribed. So those are the two. You don't need a surgical intervention for that. Now, pleural effusion. Any question on that? Okay, pleural effusion is the collection of fluid in the pleural space. Any condition that interferes with secretion or drainage of fluid in the pleural space lead to pleural effusion, the accumulation of fluid in the pleural space. I think I did this one too. So you have a sharp pleuritic pain. You describe it, and the pain will be around your pleura. You have the pain around the tachycardia, fever, elevated temperature is fever, decreased breath sounds, and affected area, chest X-ray that shows pleural effusion and mediastinal shift away from the fluid if the effusion is greater than 250 ml. So this is a fluid that goes to fit inside the pleural airspace in the lungs. So if the lungs is filled up with fluid, there will be a mediastinal shift. So in the middle, in between the respiratory compartment, there's a shift because the fluid in the pleural cavity will cause that area to move. Let's say it will cause it to bulge out. It has put pressure on the lungs. So chest X-ray will show that if the fluid is up to 250 cc within the pleural cavity or pleural space, it's going to cause a shift, and then you have pain. You have a sharp pain. If it's on the right side, you feel the pain more to that side, the pleural space on the right side of your lungs or the left side of your lungs. So when you feel that pain, there will be decreased breath sounds. So when they use a stethoscope to listen, that's why the stethoscope, you need to know the locations of the lungs. So when you listen, there will be decreased airway. Now we have the intervention is identify the underlying cause and then you treat it. Is that what I'm talking about? Yes. So we have the intervention for them to identify the underlying cause and then they treat that. Besides that, pleurectomy, removal of the stripping, surgical stripping the parietal pleura away from visceral pleura. So surgically they will go to that side of your heart and then they strip it, or they reduce it to be able to help reduce the inflammation and the tension. So this will promote adhesion formation between the two layers during healing. So after that, they give the patient antibiotics to help with, or anti-inflammatory medications to help with the inflammation. Pleurodesis involves the installation of a sclerosing substance into the pleural space via a tracheotomy healing. So this one, they go through the tracheotomy and then they try to instill something like a sclerosing substance. It's a substance, just like they will instill a dye into the abdomen to be able to view structures. So they instill this substance into the thoracic area and it be able to open up. So this substance will create an inflammatory response. So if there's already an inflammatory, then you instill a substance that will counter, that will serve as a catalyst. It will cause an inflammatory response, and that response, that sclerotic tissues, it will create inflammatory response, that sclerosing tissue with the sclerosing tissue. So when it create the inflammatory response, and then you give the patient the antibiotics or anti-inflammatory, it helps reduce the inflammation. So it's just like having a patient test positive for a virus and you give a weakened form of the virus to be able to counteract. So it causes a reaction. And when there's a reaction there, it helps balance the patient's condition at that moment. Now, emphysema is collection of pus within the pleural space or the pleural cavity. The fluid is thick, opaque, and foul smelling. Like they already mentioned, a pus. We all know how pus look like. So it's thick and pus-like. The most common causes is pulmonary infection and lung abscess caused by thoracic surgery or chest trauma in which bacteria are introduced directly into the pleural space. The treatment focuses on treating the infection, emptying the emphysema cavity, re-expanding the lung, and control the infection. Position, place the patient in a semi-Fowler's position or high Fowler's position. So mostly emphysema will cause to them putting a chest tube to drain fluid from the patient's lungs. So it's an opaque, foul-smelling fluid that come out, and it is usually caused due to, like, they have risk factors like lung abscess. You have an abscess on your lungs. So if there's an abscess on your lungs, what happened? That means the area of your lungs that was touched or the area of your lungs that is affected have the lung tissues, the muscles and the tissues that are around that area, they die off. And when they die off, they produce a liquid substance that look like pus, and that it starts smelling. It's kind of like an infection in the lungs. That's how we'll call it. So they do a procedure to drain it by emptying the cavity. So they can put a needle there and then they try to put the tube and then they drain the cavity. And the position is to have the patient semi-Fowler's or half Fowler's. The other day I told you that respiratory problems, you want to have the patient sitting up. You want the lungs to be loose, to be able to expand. When you have the head, when you have the patient in a transverse or whatever Trendelenburg position, and then you are pushing pressure on the lungs. Abdominal organs will put pressure on the lungs. Then we have pleurisy, inflammation of the viscera and parietal membranes. It may be caused by pulmonary infection or pneumonia. So if a patient have pneumonia, they can have pleurisy. So it's caused by either infection, pulmonary death, the death of the pulmonary muscle. So if the pulmonary muscle is dead, you can have pleurisy. So the visceral and parietal membranes rub together during respiration and causes pain. So let me see my respiratory diagram if I have these two things around there. Parietal and visceral. It didn't capture that. I wanted to show you. They rub shoulders. And when the two of them are rubbing each other during respiration, when you are breathing and they are rubbing each other, you start having pain. So the signs and symptoms will be knife-like pain that is aggravated on deep breathing and coughing. So the patient tells you, when I'm trying to breathe, to take deep breath, it's like somebody is poking on my lungs. Then the cough, friction, rub, head on auscultation. So when you put the stethoscope to listen to the lungs, it's like something is rubbing on each other. So you can imagine the sound if you have two objects that are rubbing on each other like this. That is the sound you hear on the stethoscope. So it's not always wheezing that you hear. That's why I was telling you the last time that if you can get something that will make you listen to the lung sounds, go for it. If you cannot get a thing that will make you listen to the lung sounds and understand them, let me know. I will try and look for some information that will contain only lung sounds for you guys. I'm not going to finish the signs and symptoms. Pulmonary embolism. This occurs when, now mind you, all the treatment for the respiratory system, they have a general treatment. Like I was asking for the abdominal problems. So when they are giving you a patient and the patient is having a respiratory problem, start thinking of all the respiratory system complications that can occur. Start thinking of shortness of breath. Start thinking of chest pain. But when you are thinking of chest pain and you see that all these symptoms are all of respiratory background, when you go to look for your answers, don't look for answers that talk of cardiac management. Look for answers that talk of relieving breath or relieving or making it easy for the patient to breathe. So when you realize that the question is directed towards answers that should be of a respiratory system, know which answers or which responses will be directed towards that system. Don't go and answer a question that will talk about obtaining EKG when the patient is having an asthmatic attack right now and is looking to breathe. Instead of talking about bronchodilators, you start talking about taking an EKG because the patient says, I have asthma and I have chest pain. You're going to do all of that, but the most important thing is that it was respiratory system involved. You want to get the patient to be breathing easy before you start doing EKG, which is chest involvement. So pulmonary embolism occurs when a thrombus forms, most commonly in a deep vein, detaches, travels to the right side of the heart, and then lodges in a branch of pulmonary artery. Clients prone to pulmonary embolism are those at risk for deep vein thrombosis, including those with prolonged immobilization, surgery, obesity, pregnancy, and heart failure. So this one is just a formation of thrombus in the lungs. So you have like a thrombus that is formed, a substance that goes to form on the lungs that will prevent you from breathing. So like a moving free blood clot goes to form in there. Then you have a thrombus that is formed in there. So a blood clot that is roaming around your body and is moving and moving and moving, it gets stuck at a point in your lungs. So you have pulmonary embolism. Now, signs and symptoms is apprehension, restlessness, blood tinged sputum, chest pain. So these are always common symptoms. I don't like to dig too much into that. Now you want to notify the provider. You want to notify the rapid response team and the primary healthcare provider. The moment you see the patient's symptoms are suggesting pulmonary embolism, something is in the lungs that is making the patient not to breathe. And you will see the patient will describe the pain and you have to rush to notify a rapid response team because the patient cannot breathe at that point. So that's one of the urgent management you want to give. Histoplasmosis. This one is a fungal infection that is caused by spores of Histoplasma capsulatum. Transmission occurs at the inhalation of spores, which are commonly found in contaminated soil. Spores are usually found in bird droppings. So you find spores in bird droppings when you get in contact with them and you inhale them. So for instance, if you have ever been to where they rear birds, let's say chicken, you enter the live chicken store and you see their dander, you smell it. Those people who work there, they get in contact with some of these things. The symptoms will present similar like a pneumonia. There will be positive skin test for histoplasmosis. So they do a skin test just like we do the tuberculosis skin testing, and positive agglutination test and splenomegaly and hepatomegaly. Your spleen will be enlarged, your liver will be enlarged. Now I put lung cancer and laryngeal cancer. I have a section that talks about cancer and then carbon monoxide poison, but I didn't go into details of that. So we all know that we have benign and we have metastatic cancer, which is fast pacing into people's lives these days, that a lot of people present with cancer. So let's go and study more about cancer because you're going to see a question of a patient presenting with cancer. Most of the patients presenting with cancer when you do their blood work, you will notice that their white blood cells are low. They have neutropenia most often. That's what will give them a suspicion to look for cancer. Neutropenia, low white blood cell. If it's white blood cell, if it's elevated white blood, WBC, you are concerned about infection. But if it's low, you're concerned about neutropenia. Is there any problem in the blood? Leukemia, cancer, those things. You look for it in neutropenia. Now, sarcoidosis. This one, sometimes a lot of people or a lot of students get confused if it's respiratory or is musculoskeletal. This is a respiratory one. They have scoliosis and lordosis and all those things in skeletal deformation. But this one is a respiratory sarcoidosis. It's a respiratory problem. And this one is the presence of epithelioid cell tubercles in the lungs. So when there are epithelioid cell tubercles in the lungs, that's sarcoidosis. The cause is unknown, but a high titer of Epstein-Barr virus may be noted. So when you do Epstein-Barr virus, when you do the titers for it, they want to check if you have ever had that virus. I want you guys to go and look at what Epstein-Barr virus is, or Epstein-Barr syndrome. We have a problem like that. When they do the titers for it, they will realize that the titers are very high. That means you have ever either taken a vaccine for Epstein-Barr or you have had Epstein-Barr virus. You have been affected by this virus. Then when they do the titers, they're going to realize that it's high, but your complaint will be of lung related. So if that is your complaint, they will see epithelioid cells tubercles in your lungs. So when they see that and then your titers too are high, then they suspect that you have this one. So those are the two things that will notify the provider what your problem could probably be. Now, viral incidence is highest in African American adults and young adults. So we have some diseases, like if they're talking about hypertension, and they're talking of cultural location and all those things, you always want to look for African Americans because they have a higher rate. And according to records shows that African Americans die of high blood pressure issues than any other ethnic relation. So the signs and symptoms will be night sweats, fever, weight loss, cough and dyspnea, skin nodules, polyarthritis, Kevin test. A Kevin test is sarcoid node antigen, is injected intradermally and causes a local nodular lesion in about 1 month. So just like they do the skin test for the what's the name, the PPD. So just like they do the PPD, this one they inject it intradermally. They also inject that one intradermally. In 1 month, they expect to see a nodular lesion in about 1 month. So that means this particular problem is not diagnosed right away. There are things that will lead them. So the patient comes to tell you, for the last 6 months, I've been losing weight. I sweat a lot in the night. Now, let me give you a typical example of a patient I've had with this problem. So the patient come in and tell me, oh, I work with some international company and I've been traveling a lot. But for the past 7 months, I've been losing weight. I've lost like almost 60 pounds of my weight. I do eat a lot. Sometimes I cough, but my shortness of breath is not so obvious. I don't think I'm short of breath. But the weight loss is making me concerned, and sometimes I sweat at night. So the first assessment we did was to assess the patient for thyroid. But thank God for NCLEX. NCLEX is not going to give you a general assessment list. NCLEX is going to limit you to exactly what they want. So if they want you to assess the patient for this particular disease, the patient has been feeling this way for 7 months now and have lost over 60 pounds. This is not normal. So the NCLEX will go further and tell you, oh, they injected sarconoid antigen, or they gave the patient an injection. They don't want to mention the name to suspect, for you to start suspecting this particular condition. They tell you the patient got an intradermal injection, and within 1 month, there was a nodular lesion that developed on the patient's skin. What will the nurse do? They want you to know the intervention management, or which of the following medications will the nurse consider administering the patient. That's what NCLEX is going to present for conditions like this. So I'm just mentioning some of this for you to have an idea that this is a condition that exists, and I have a baseline information. You don't need to know details. You just need to know that it's part of respiratory problems that can happen. Yeah. So the intervention is corticosteroids, monitor temperature, fluid intake. This will all be, I will do all this for most of the respiratory systems, because it's not renal, it's not cardio that will cause fluid accumulation. Now we have occupational lung disease. This is caused by exposure to environmental exposure, film, dust, vapors, gases, bacteria, antigens, allergens, and other reversible effects or chronic lung disease. So the most common classification include occupational asthma. So we have asthma that is as a result of the occupation you do. I don't know if we can figure this out, but they can give you a question that they tell you that you work at a sawmill, or the patient tells you, I work at a sawmill, or I'm a construction worker. Those places, they do things that produces either fumes, gases, or dust. So they are describing the location the patient is working. They are not describing asthma. They are not describing any irritant that can cause asthma. So those are the things you want to know. So they tell you the symptoms, and then they want you to be able to figure it out. Like we see asbestos here. All those things are occupational lung diseases. So asbestos, talcosis, berylliosis. So these are the things NCLEX like to talk about. They look for conditions that sound a little crazy. That's why the other day I was able to formulate a condition of my own. They don't want to mention the familiar disease conditions to you. So those that are familiar, you know them already, and they know what you look out for. So one thing I'm going to urge you guys to do is to go and study most of the conditions that fall under the systems that are not more familiar. Those are the things NCLEX will mention to you, and you are like, I have never heard this before. It is there. You will find it. It's just that it's not a most commonly diagnosed thing, and or a most commonly talked about situation. So you don't think they exist. Those are the things NCLEX look for. Those words that doesn't make sense. They tell you the patient has talcosis. You should know that talcosis is an occupational problem, lung disease. If you know it's related to the lungs, answering the questions will be easier for you. I don't know if we understand it. But if they go to mention occupational lung disease, they tell you it's lung, then you are good. Yes, you'll be able to figure it out, but they won't tell you that. They go to look for berylliosis, and then you are all off if you are not careful. Then the signs and symptoms depend on the type of disease and our respiratory systems. So prevention is through the use of respiratory protective devices. Treatment is based on the symptoms experienced by the client. So for you to be able to tackle occupational lung disease, so if the patient has a lung cancer and the lung cancer is due to asbestos, then you are tackling it as a cancer problem. If the patient has pneumonia, and the pneumonia is as a result of exposure to cold things or exposure to the weather, then you know what to tackle it from. If the patient tells you I have asthma, but I work in the industry, the manufacturing company, then you know the irritants. So just like asthma will tell you to look for irritants, like irritating causes of the asthma, so that the patient will be comfortable. Treatment of this one, or interventions or education that you tell the patient, is to tell the patient to stay away from irritating causes or things that will cause it. Now, tuberculosis. I'm going to jump more of this part because I know tuberculosis, we have gone over it, or you guys know what tuberculosis is. So I want to talk about the onset. So the onset has an insidious onset. It's caused by mycobacterial tuberculosis. Okay, that's what it is called. I don't want to go into that. I feel like it's wasting time. But tuberculosis has an insidious onset, and many clients are not aware of the symptoms until the disease is well advanced. So most people usually doesn't know they have TB until the symptoms are well advanced. That's the problem. So improper or non-compliant use of treatment program may cause the development of mutation in the tubercle bacilli, resulting in a multi-drug resistant strain of tuberculosis. So just like we have the MRSA, the multi-resistant drugs for antibiotics, tuberculosis too, we have multi-resistant. When a patient is not compliant on tuberculosis medication, the patient can develop multi-drug resistant strain of the tuberculosis. So you'll be treating the patient is not going. So all the standard treatment for tuberculosis, the patient will get everything and it will still go. That means the patient is coming back with all those problems after treatment for 6 months or 9 months. The patient still has the tuberculosis in them. You want to question, is the patient compliant to the treatment? So the goal for treatment is to prevent transmission and control symptoms and prevent progression of the disease. Now, transmission is airborne route by droplet infection. So the mode of transmission is airborne and is through droplets. So you want to use airborne and droplet. So when an infected individual cough, laugh, sneeze, or sinks droplet nucleus containing the virus, if you inhale it, you're gonna get it. So mostly a patient presents to you and the patient symptoms are they start showing you the symptoms and you think it's tuberculosis, you want to put the patient in isolation. So the risk factors are children younger than 5 years of age, drinking of unpasteurized milk, if the cow is infected with bovine tubercle. So take note of this particular one. They can mention this one. I think I've seen it somewhere in the NCLEX before. They will not mention the particular cause of it, but they'll tell you bovine tuberculosis. So this one is from infected cows. Homeless individuals or those for a low socioeconomic group, minority group, or immigrant. I'm going to jump that. Now this notes, I said recent bacilli calmate Gurinba vaccine. This is the BCG. Usually they call that BCG. That's the vaccine that most of us in Africa, when we get it, that scar doesn't go away. That's the BCG. It's a vaccine containing attenuated tubercle bacilli that may be given to persons in foreign countries or to sponsor traveling to foreign countries to produce increased resistance to tuberculosis. An individual who has received a BCG vaccine will have a positive test result and will be evaluated for tuberculosis with an X-ray. So this explains why most Africans who come from Africa and then they come and they do the PPD testing and they come positive and they know that my family member has never had tuberculosis. But if you were born starting from the early 80s, 1981 coming down until now, from those areas, they give you the BCG vaccine. So it's attenuated tubercle bacilli. Attenuated means they have weakened the virus and then they put it in you. So when they do the skin testing, it comes back positive. That means they have put the virus in your body, but they are not strong. They are the weakened form of the virus in you. So they protect you from getting the tuberculosis. So that's what that BCG vaccine is. They give it to children mostly. But when you grow up, I grew up with that mark and it's still on my arm. That vaccine will always give you a mark for life. The clinical manifestations for tuberculosis will be asymptomatic. In the beginning, the patient will be asymptomatic. There will not be any symptoms. but the patient will have fatigue. Sometimes we have fatigue, we don't pay attention to it. Lethargy, anorexia, weight loss, low-grade chills, night sweats, persistent cough, and the production of mucoid and mucopurulent sputum. So these are the things NCLEX is more focusing on: the weight loss, night sweats, and the cough, persistent cough. Those are the symptoms most often they like to use to describe the patient has TB. So those three symptoms they like to focus so much. The other symptoms, other respiratory system can manifest them. So far as your respiratory tract is not in order, you can manifest them. But this persistent cough and productive of mucoid, and then weight loss and night sweats. Remember the lung one we just did, the scardosis, this cicadosis also has night sweats and weight loss. But remember the persistent cough in tuberculosis never changes. So chest x-ray is not definitive, but the presence of multinodular infiltrates with calcification in the upper lobes supports tuberculosis. So when we looked at the lung has 5 lobes. The right one has 3 different lobes, and the left lung has 2 of them. So in the case of tuberculosis, you are going to see nodules. When you look at the chest x-ray, you see the problems on the upper lobes. So these are the upper lobes. So the right has 3 lobes, the left has 2. So you look at them, the upper lobes is what will be infected. So you see nodules, it will be like opacity, some kind of covering, blockage that is blocking that side. So that's the one that the x-ray will look for to tell you. But they say x-ray is not definitive. It's not to confirm the diagnosis. You have to see those blockages. And they have to also do a quantiferum gold test. And this one is a blood analysis test that is done by enzyme-linked immunoabsorbent assay. So they run a blood test on the patient. They take sputum cultures. Now, NCLEX, we want to know what time of the day is best to collect sputum. It's early in the morning when the patient wake up. So they collect the sputum, and then they also do the skin testing. So when they do the skin testing, they give you the PPD injection. It doesn't go into your body, it stays on top of the skin. So if there's a reaction by causing an induration, then they think you have to do x-ray, and the x-ray will confirm if there's active blockage, opacity, or multinodular infiltrate that calcify in the upper lobes. That will direct them to now go into the blood work. So they will now do blood work to confirm all of that. Now the hospitaler clients should be placed in under airborne room, precaution, negative pressure rooms. So tuberculosis patients need a negative pressure air rooms. The door of the room needs to be closed tightly. Back home in some areas, they have a particular hospital for them. They separate them in their care. They call that site isolation. And when they discharge you from there, they don't send you home. They have a program, they keep all these patients. So client education, you want to educate family members about tuberculosis and also concerned about the contagious aspect of the disease. So most often, in the NCLEX with tuberculosis, they are going to tell you that you were recently diagnosed with tuberculosis, and now your daughter wants to be eating with you every day. And they give you an option like there is no option than for you to eat with your daughter, even in the same bowl. So you can only eat with your daughter after you pass the infection stage. But during I'm here to get the infection stage right. I don't want to tell what's not right. During the infection stage, 2 to 3 weeks of medication therapy, it is unlikely that they will infect anyone. So the infection stage is 2 to 3 weeks. So within 2 to 3 weeks, when you start taking your medication and you take it right, after that 3 weeks, you will not be infectious again. So you can eat with your family members. So they tell the patient was discharged from the hospital 3 weeks ago or 4 weeks ago, and is now home. So if the patient is now home, you can still keep the patient in the separate room in the house. But there is nothing wrong eating with the patient. So most of the answer options, just be careful. It gets to a certain stage that you cannot eat with your relative. You cannot share spoons, you cannot share things. HIV/AIDS, they will also ask you questions on it because they want to know if you understand the mode of spread. Hepatitis B, they will ask questions and relate it to family members and how they want to be able to accommodate. Remember, when you are nursing a patient, you are nursing the patient and the family because family members also have concerns. Okay, so I advise the client that the medication regimen is continued over 6 to 12 months, depending on the situation. Advise the client that the side effects associated with the medication and ways of minimizing them to ensure compliance. Reassure that after 2 to 3 weeks of medication therapy, it is unlikely that they will infect anybody. So this is a point I wanted to make. Of course, you want to instruct them about nutrition, which is very important, and inform them about exposure to. So you inform them about hand washing, and you inform them about sputum culture that is needed every 2 to 4 weeks. NCLEX like to question this. So how often do you do sputum culture for a patient that has tuberculosis? It's every 2 to 4 weeks once the medication therapy has started. So before the medication therapy is starting, they take the sputum cultures, and after they took the first sputum culture, they start the medication today. After taking the culture, they start the medication, and every 2 to 4 weeks, we repeat it. So after the whole treatment process, you want to get 3 negative sputum cultures to confirm that the patient is no longer infectious. So this is the end of that part of the studies. And then I'm just going to jump into the medications for this. Any question? Are we on?
Yes, we are.
Okay. Any question?
So, question. Before they actually start taking the medication, do they take a sputum culture, or is it after they do the after the medication starts?
In the beginning, or what's the question again? Can you repeat it?
Yeah, I'm asking. You said the culture is taken every 2 to 4 days, right?
2 to 4
After you
weeks.
start
Every 2 to 4 weeks whilst you are taking the medication.
before the medication starts, they don't take a sputum culture before?
They do. So
Okay.
before the medication starts, they do the quantiferum, and then they do a chest x-ray, and they do the sputum test. So the sputum test, the sputum test come in several sputum containers. They will take a lot of sputum from you, and they put them in different containers, but all is to test towards confirming the virus in you. And when they confirm the virus, then they now start. So once you start taking the medication, so let's say the client came in today and they did the testing today, and the results come back tomorrow. But before tomorrow, you the nurse, if you suspect this is TB, because the actual result will come back right away. So you see the noodles at the upper lobes of the patient lungs, the upper right and left lobes. You want to caution the patient first thing and tell the patient, listen, when you go home, you have to isolate. You have to stay away. we're going to call you with the result. So when you call the patient with the result, and when you receive the sputum cultures and all the other results, and it's all negative, positive, then you are going to advise the patient every 2 to 4 weeks, you come back for repeat testing, and that is to confirm that the patient is infectious at this stage, or you want to confirm the viral load in the respiratory airway for the patient. So when that is reduced, you will see that the patient is no longer infectious after the patient has complied with the medication. Now, if the patient is not compliant with the medication, every 2 to 4 weeks, when you do the blood work, you will still notice that the viral load is now reducing. That means the patient is now compliant. So at a point, the patient develops multi-resistant, resistant to the medication, because you take it today, and tomorrow you don't take it. You take it today, 2 days time, you don't take it. So in that case, the patient will develop resistance. The virus will develop resistance to the medication. And that's when managing it gets more difficult. And after the 12 months, if the regimen is supposed to be between 6 to 12 months. So when NCLEX is giving you questions and that, usually they like to go very specific. They want to know if you really understand the timing for the treatment. So some of them can be, they'll put them for 6 to 12 months. But 6 to 12 months, in between that is 9 months. So by that time, some people stop the treatment. If they are compliant and they follow everything in order, 9 months, they stop the treatment. If after that, they get 3 negative sputum tests, they stop the treatment. But if they move it all the way to 12 months, after 12 months, they expect to get negative sputum cultures. So the negative sputum culture test will start after the last dose on the 12 months. So we finish the last dose today, then I come and take it. Okay.
Okay.
I have a question. Yeah. If, I saw some questions sometime where a family member, how do you treat family members? Because knowing that TB is very contagious, and then the patient doesn't even know that he's having it or she's having it. Meanwhile, he's already in a family situation, in a family setting, before he's now diagnosed. How will the rest of the family be treated? Because these ones are not manifesting the symptoms, but they are being exposed to a family member who already has it.
Yes, so if you have been exposed to a family member who has it, and you are not exhibiting active symptoms, you need to do the what's the name? The skin test. That's where they will request for you to do the skin test. And when the skin test come positive, then they follow up with an X-ray to see if you have active of it. Because you may not exhibit symptoms. Like I had mentioned before, patients don't usually exhibit active symptoms right away. So because the tuberculosis, you don't show the symptoms right now, and the time you start showing, maybe probably at that time the infection stage is past. You have infected.
No, what I want to say is any prophylactic treatment, because even if you do the test at that time, even if you do the PPD at that time, it will still be negative.
Yes, so most often in those cases, they want to advise the family if the person is was treated as having positive. They don't want to put family on prophylaxis because it's everybody who was in this house. So they only want to test you. They only want you to do a test to be able to be sure that you are also actively infected. How about if I was with you in the same house and I don't get it? So they only advise the family to also monitor themselves for a certain period of time to see if they start manifesting symptoms. And then they should not delay to do the skin testing, which is a directive and they teach the family too as to how to now become more cautious. And if you think you have already been exposed, you don't hesitate. If you think it's the symptoms you are actively, they show you the active symptoms you will bring up. So in the next 2 to 3 weeks, I tell you, so if in the next 2 to 3 weeks, you start exhibiting these symptoms, don't waste time. You have to get tested. But if it's a question that is directing you to do something with the family members, then you want to put the family members on, you want to educate them as to how to identify the symptoms of active TB in them. And when they identify it, they should start taking treatment right away. But you can't just put the whole family on prophylaxis, on the NCLEX. NCLEX don't give you too much medication, you know. They only give you one for their patients. Yeah, they don't want to give it too much for everybody in the family. You can only educate the family to be on the alert, and you tell them the infectious period, and then you tell them what has happened. So when the family understand, then they also now start monitoring themselves. So within 2 weeks, I don't develop symptoms, I'm fine. It's just like the COVID. Most often, people that go to the hospital, they diagnose them as COVID positive, they discharge them back home. But they give them home instructions. They advise them as to how to stay at home and feel better. I didn't look at my time. I didn't know the time was gone. You guys don't stop me. Huh? You need to stop me. Do we need to take a break or we should just finish up? Are we on? I have a little
strength. Let's go.
Yeah, I have a little headache today, so I'm going to jump off early. My cold is still that one.
Can I ask you something? The last the GI system that we did, I was trying to review it, but I don't see it in Google Docs.
Yes, I'm listening.
No, I said I was earlier today, I was trying to read over it, but I couldn't find it in the
Oh, the GI?
Yeah.
I will check. I don't think I put a time limit to it. So I will check and see what happened, but I didn't put a time limit for you accessing it. So I will go over it and check. Okay.
Okay.
And then when I finish, I have a document here about blood transfusion. I may not be able to go into that document, but I wish you guys can go over it and practice with questions.
So the other side, go at the end of the hallway and just make a left, and then you follow the hallway and it's right.
Okay, so I'm going to jump quick on this one because next week I want to talk about my two favorite systems, that is cardio and renal. I want to be able to finish that, and then we dig deep into comparing our content with the NCLEX questions. So I want to jump on this. So the respiratory medications, we have the inhaler devices, that's the meter dose. We have done that one already. Now, if two different inhaler medications are prescribed and one of the medications contains glucocorticoid or steroid, administer the bronchodilator first and then the steroid second. And if two different inhaled medications are prescribed, instruct the client to wait 5 minutes following administration of first before inhaling the second. If a second dose of the same medication is needed, instruct the client to wait 1 to 2 minutes before taking the second dose. Do we get that point?
Yeah.
Yes.
So we would do the regular medication and then the steroid medication afterwards?
Yes. So we give bronchodilators first. Bronchodilators are the nebulizer treatment, you know, albuterol, ipratropium. Those are mostly the common bronchodilators they use. So NCLEX is not going to mention bronchodilators. It's going to mention a medication name to you. Okay? So they will mention the medication name to you, and then they want you to be able to know if it's a bronchodilator. In the last end of this presentation, I have all those medications. So all the medications that end in the terol, like albuterol, aformoterol, they are all bronchodilators. Anything that end in T-E-R-O-L, they are bronchodilators. So it's not only albuterol and ipratropium or albuterol. Albuterol is mostly the bronchodilator. So it's not only albuterol, there are other medication, but when you see any medication ending in that section, you want to think it's bronchodilator, you give that one before you give the corticosteroids. I have a whole book on that. When I finish these two more systems, we'll jump on pharmacology for 1 or 2 days and then we'll kick it off. It's a whole book, but I'm going to try to summarize that book. Now, bronchodilators, do we need to know this or we'll just read that one? Let me go to this one. The note. Used with caution in clients with hypertension. So if a patient is taking bronchodilator, you want to use it with caution. Patient with hypertension, diabetes, or narrow angle glaucoma. So these are the cautions you need to take note of. Patients that have any of this, you want to tell them to use that with a caution. They don't just take it, but you be careful because it can increase the blood pressure. So theophylline increases the risk for digoxin toxicity and decrease the effect of lithium and phenytoin. So if a patient is taking theophylline, I think I jumped that portion, but theophylline is one of the medications. It's a methyl-xanthine or bronchodilator. It's a bronchodilator. Theophylline is a bronchodilator. So it stimulates the central nervous system and respiratory system. It dilates coronary and pulmonary vessels, cause diuresis, and relax smooth muscles. So the example is theophylline. It's used to treat acute bronchospasms. So because it relaxes, it works on the central nervous system and the respiratory system, it relaxes, it's good for bronchospasms. When the bronchioles are spasming, like in asthma, we talked about asthma causing spasms and inflammation of the bronchioles. So when they are spasming and you give that theophylline, it will relax them because it works on respiratory muscles. And then acute chronic bronchitis, restrictive airway disease, and active reactive airway diseases. So it's contraindicated in individuals with hypersensitivity. Now listen, all respiratory system medications are contraindicated with patients who have hypersensitivity. Okay? Hypersensitivity means you have taken that medication before and you reacted, or you took a similar one of it and you reacted, or you have taken the same medication, you had a problem. That's hypersensitivity. Or you are sensitive to a lot of unnecessary things. You want to also be careful taking this medication. So that doesn't mean if a patient has a hypersensitivity. Now, this brings me to another comment I've been trying to remember. Some of the things just come when I'm talking. NCLEX want you to know, I think I said that before, a patient can be allergic to something that the patient comes, and then you compare the patient's current situation as to whether to give this particular one or not to give. If that is the same one that will bring life into the person, NCLEX will not put you in a situation that is too tight for you to understand. They will tell you the patient would have said, I have this, I have taken this one, and I developed a rash. You understand? But right now, the patient is actively reacting and actively having a reaction. Now, NCLEX want to know what is the next step you will do. So in those options, they'll give you an option like you give it and then you monitor the patient, or you have the doctor order an antidote whilst you give the medication and monitor. Such an option will be correct because sometimes if they compare how effective this medication will help you and how much the adverse effects will also affect you. So if they realize that the adverse effect is not going to be life-threatening and there are antidotes readily available for you to give on the NCLEX, those options will always lead you to the right one. Now, mostly pharmacology on the NCLEX will always be direct forward questions. Pharmacology doesn't go with prioritization, even though they'll ask you which medication will you give first. That is it. But with pharmacology, one thing I'm trying to let you know is that you have to know the class of the medication. Pharmacology will always be content questions on the NCLEX. They're straightforward. If you understand the medication, the symptoms they are going to present, you're going to look for that particular medication. And when it comes to pharmacology calculations on the NCLEX, sometimes they will just put the question and then they'll put a word that you don't need it in the formula. When you are calculating, you don't need that in the formula, but they just put it there to see if you are going to fix it somewhere to get a wrong answer. And that need to always be short questions for you to answer on the medication aspect of pharmacology. So that you just need to know the straightforward content. You don't need to be crazy about twisting pharmacology to physiological need and all those things. No, you don't twist pharmacology like that. That one is straightforward. You are giving bronchodilators because the patient has an airway problem and it's not a GI problem. You are giving antiemetics because the patient has a GI problem and is vomiting. You are not giving it because the patient has difficulty breathing. That's it. So those are straightforward as to what is supposed to be used for. So mind you, respiratory system medications will always talk about respiration answers in the NCLEX. It doesn't cross. Now, let's continue with our theophylline. So theophylline increase the risk of digoxin toxicity. So risk for digoxin toxicity. If the patient is taking digoxin and you are giving the patient theophylline, you want to be careful about increased risk and decrease the effect of lithium and phenytoin. So phenytoin is a anti-seizure medication. So you want to take note, it will decrease it. So if I'm already taking this for seizures and you're giving me theophylline because I'm having shortness of breath today, tomorrow I may get a seizure attack. So they're just telling you to take note. It doesn't mean you can't take it, but monitor the effectiveness of both. Remember phenytoin, we have to always do blood work for the phenytoin. We have to always do the peak and the trough. So you monitor the phenytoin level in the patient. So theophylline should be at least line medication. If the theophylline and a beta adrenergic antagonist are administered together, cardiac arrhythmias may result. So we're here to get to the beta adrenergic agonist. Now, beta blockers, cimetidine, erythromycin increase the effects of theophylline. So if I start taking cimetidine and I'm taking erythromycin, and then I go to take theophylline, it will increase the effectiveness. So that means if my beta blockers were now effective, in reducing my blood pressure and I take theophylline, it's going to reduce it. It's going to work more. So it jump-starts it. Now the side effects is palpitations, dysrhythmias, restlessness, nervousness, tremors, anorexia. Now another thing, mind you, these are medications that you are given in the respiratory system. So it is obvious to have tachycardia when you are taking most of these respiratory medications because they are trying to kickstart your heart, your respiratory system. So most of this will present with tachycardia, palpitation. You see all those symptoms, respiratory symptoms, you are fine with that. It's initiating all that to come up from the heart because they are all connected. So anything that will cause the respiratory system to move faster, it pushes back to the heart. And then you see that the heart starts manifesting these symptoms like tachycardia, palpitation, dysrhythmias. So that's how the two are interrelated. So when one is affected, the effect comes back and bounces on the other. And then when you are taking those medications, it affects the other one. Now the intervention is assess lung sounds, monitor cardiac dysrhythmias, assess for cough, wheezing, decreased breath sounds. I will do this for all respiratory problems. So these are common symptoms. So you educate not to crush enteric-coated sustained release tablets. Well, avoid coffee containing products such as blah, 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 blah. This I don't even want to ever do. So on the NCLEX, when they present you with questions and they want you to choose negative answers, which one will indicate to you that the client does not understand the teaching? The patient tells you, I'll take it with tea, I'll take it with coffee, I'll take my medication with cola. Sometimes they try to now eliminate coffee because they know it's so obvious, coffee and alcohol and smoke. They want to eliminate those symptoms. Then they start using tea, then they start using chocolate, and they use over-the-counter. I have over-the-counter medication in the house that is always helping me. And culturally, I'm not allowed to stop it. I'll use it. Then you want to re-educate this patient as to what to take with the hospital-made medications. So theophylline toxicity likely to occur when the serum level is higher than 20 and 11 micromole per liter. Early signs of toxicity include restlessness, nervousness, tremors, palpitations, and tachycardia. So these are the things I will only know for signs of adverse effects for theophylline. This is what I'll be worried about. These are the signs and symptoms I'll be worried about because this look like, especially tremors, that look like a little way of a bigger problem and restlessness. But the other ones are normal signs you will have. So a level of higher than 20 is a level that is higher than 20. That means the patient will start manifesting early signs. So that means from 0 to 20 is what you expect the normal to be. So above 20 is a question mark. And when it's up to this point, at this point, you are expecting the patient to be in a different level. So that's too much for the patient. Anticholinergic. Is there
any antidote to theophylline toxicity?
Let me check that. There will definitely be an antidote for that. I'm going to put it down. Antidote for theophylline. Antidote. Thank you for reminding me that. Theophylline. Now let's go to anticholinergics, inhaled medications that improve lung function by blocking muscarinic receptors in the bronchi, which prevent bronchoconstriction. Effects for treating chronic obstructive pulmonary disease, allergy-induced asthma, and exercise bronchospasms. Side effects include dry mouth, irritation of the pharynx, sucking on sugarless candy will help relieve symptoms. So that's it. Anticholinergics, anything that will cause dryness in your throat, is to help relieve the bronchoconstriction in your lungs, in your pharynx. So anything that you will help, you take sugarless candy, will help relieve the symptoms of that. Okay. So the client with a peanut allergy should not take certain ipratropium products because they contain soy lecithin, which is in the same plant family as peanut. So the anticholinergics, now this is how it is administered. So you give the first line of treatment is bronchodilators, which is the albuterol family, and the anticholinergics is the ipratropium. That's why when you combine the albuterol and the anticholinergic, so when you're giving ipratropium and albuterol, those are two different medications. So the albuterol is a bronchodilator and the ipratropium is an anticholinergic. Those go together in the case of asthma before steroids come. So when you look at these medications that I put out, they are lined up in order. So the first one I spoke about was the yes. So the first one was the inhaler, then to the bronchodilators, and now this is anticholinergics, and the next one is glucocorticoids. So all of them you want to monitor for tachycardia. So ipratropium is one of the nebulizer inhaler treatment that they mix with albuterol. But albuterol is a bronchodilator. It dilates the open airways and open the airway. Then anticholinergics go into the muscarina. It blocks the receptor agents in the bronchi, and this one will prevent the bronchoconstriction. So whilst this ipratropium is trying to open them apart, while albuterol, which is bronchodilator, is trying to separate them, trying to dilate it. So to dilate means to open, trying to make way. The anticholinergics also prevent the spasming. It helps prevent the spasming. So you are pushing me to move on the side and I'm still shaking. And the anticholinergics will help stop those spasming and then allow that's the vasoconstriction. It allows that to have the steroid to now go into the small portion because everybody is now relaxing. So one is opening, one is causing relaxation of all the bronchial alveoli. So whilst they are relaxing, then it's able to relax and then steroids will help open up to breathe. So glucocorticoids act as anti-inflammatory agents and reduce edema of the airway. They are used to treat asthma and other inflammatory respiratory airways. So remember when we talked about asthma, we said asthma was spasming and inflammation of the bronchioles. So glucocorticoids are anti-inflammatory that help reduce the inflammation. So when all these things, these two bronchodilators and then the anticholinergics are active, the inflammatory agents come in to reduce inflammation. Now you want to educate the client to take the medication 1 hour before or 2 hours after meal. So this is also a thing you want to note with other medications. Try to note which medication can be eaten with meal. In respiratory, I know I had mentioned them, some cannot be eaten with meal. Cannot eat some medication with food. Now, the inhaled non-steroidal anti-allergic agent, that's antihistamine. So we have some anti-allergic medications that we inhale them, and that's antihistamines. We have several medications that are antihistamine, but some are for inhalation purposes. And mast cell stabilizers inhibit mast cell release for exposure to antigens. They are used to treat allergic rhinitis, bronchial asthma, and exercise-induced bronchospasms, contraindicated in clients with known hypersensitivity. So I'm going to start jumping this particular symptom because this known hypersensitivity is going to be for all of them. I don't know who know this one, who has seen this non-steroidal anti-allergic medication, but places where you can get it to buy is over the counter most often. You can even get it over, even though they prescribe it, but it's mostly over the counter. You put it in your nose and you block one nose like this and you inhale on it. I don't know who has ever done that, who has seen something like that. That the person will just buy it from the store, and then you put it on your nose and you inhale it from one nostril, and then you put it on the other nostril and you inhale it. Those are the antihistamine, anti-allergic medications. So they are mostly over the counter, but they can prescribe them when needed. So side effect. The side effect is cough, nasal sting, your nose will be itching, or bronchospasm following inhalation, and pleasant taste in the mouth. Yes, if you have ever done it, you have a pleasant taste in the mouth. I remember my daddy used to use that a lot. That's my daddy's favorite medication. So I knew that one when I was a child. Yeah, okay. So the intervention is to monitor respiratory rates and assess the lung sound for rhonchi or wheezing. So anytime you give it all these medications, you want to monitor all these symptoms. Educate to administer oral capsules at least 30 minutes. So now I just mentioned only the nasal spray for the antihistamine. We have other antihistamine medications as well. Antihistamine, I think, like, what's the name? Oh, I'm trying to forget the medications like that. So we have other antihistamine medications that are capsules. What's the name? Oh boy, Benadryl, right? Benadryl is one of them. I want to get more of this antihistamine. I'm going to get a bunch of them. We have a couple of them. I know about Benadryl. I know loratadine. Loratadine too is an antihistamine. So those are, but I'm going to get more of the antihistamines. I have all of these medications names under at the end of this presentation. I was making the study note, but I didn't get to go over it, so I didn't finish it. But I have all those medications. I'll bring them a list of them for you guys to follow. And then we have the side effects of that. Now let's talk about monoclonal antibodies. Omalizumab. This is the current medication they are giving for the COVID patients. So this one is, even though the one for COVID, they say it's not authorized by FDA, but we've had that medication before. It's just that it was used in a different form. Now they are converting it to be able to counteract the COVID virus. So it's a medication that we have had before. It's a recombinant DNA-derived humanized immunoglobulin G, that they call monoclonal antibody, that selectively binds to immunoglobulin E to limit the release of mediators in the allergic response. The use is to treat allergic-related asthma, administered subcutaneously every 2 to 4 weeks. Dose is titrated on the basis of serum level and body weight. So now they have, you can see the same medication that they are using for COVID, but this one is in favor of asthmatic treatment. It's not in favor of COVID, but they have another form. So this one is, they say, humanized immunoglobulin. The one for the COVID is not humanized immunoglobulin. They said it's just a preparation that was prepared in the lab to mimic the COVID virus, and they use that one to treat the COVID, and it's not a blood product. So the monoclonal antibody we are hearing for COVID is different from this one. We have another monoclonal for asthmatic treatment, and that is given 2 to 4 weeks, and it's being titrated based on how the patient is responding. The same hypersensitivity. Now the side effects: injection site reaction, sinus, headache, pharyngitis, anaphylaxis. Anaphylaxis will always occur in several medications that a patient reacts with. So note that symptom. Antihistamine, also called histamine antagonist, H-beta blockers. This medication competes with histamine on receptor site. I think I spoke about antihistamines. Listen, drowsiness and fatigue. Antihistamine, just take what's the name? Benadryl as an example. Loratadine. Those are medications that will cause you to be sleepy. So Benadryl has an anticholinergic effect and should be avoided in clients with narrow angle glaucoma. So take note of this. So patients who have narrow angle glaucoma, they should avoid Benadryl. But we know the side effects of it already. Drowsiness, fatigue, it makes the person sleepy, photosensitivity, hypertension, dry mouth. It's a lot of them. It's contraindicated or used with extreme caution in clients with hypertension, cardiac, hyperthyroidism, or diabetes mellitus. Intervention is to monitor for cardiac arrhythmias, monitor blood glucose, cause of its reaction. I'm going to go to expectorants or mucolytic agents. Expectorants loosen bronchial secretion. So when you take expectorant, your intention for taking them is to thin the mucous secretions in your throat. So when expectorant will help it come up. We have medication like dextromethorphan that helps. It's an expectorant. Like you see some people taking dextromethorphan is like, I'll say, the cough syrup. The people call it, the older people, the next one have a name for it that they call it. They take that one and they help them to expectorate. So now it thins the secretions, and instead of it being thick and not able to come out, it starts thinning, and then you are able to, like, you bring it out and spit it out. So those are expectorants. It helps in expectorating thick secretions. So mucolytic agent that agents thin mucous secretions. That's what I just finished explaining. So the side effect is gastrointestinal irritation, rash, or pharyngeal irritation. Most of those medications, some of them are liquid, and when you take them, it's irritating your stomach. It doesn't even taste nice. But listen, our older people, they like it. Guaifenesin, yes, cough syrup. They call it cough syrup. Guaifenesin and all those things are expectorant. It helps you to expectorate. It thins the mucous secretions and you bring it out. Intervention, acetylcysteine is one of them. It's administered by nebulizer, which should not be mixed with another medication. So this acetylcysteine, I think they have another name for it that will be more familiar. But you need to know that it is one of the expectorants. It can increase airway resistance and should not be used in clients with asthma. So it's also a medication that will thin secretions, and it should be administered 5 minutes before. Bronchodilator should be administered 5 minutes before acetylcysteine. I'm going to look for example of that medication and show you as a picture. Now, client education: to take the medication with full glass of water to loosen secretions. So when you take the medication, you carry fluid. To cough and deep breath, and then to take adequate fluid. I said that. Antitussive medications act on the cough control center in the medulla to suppress cough reflex, used for a cough that is non-productive. So these are cough syrup. Antitussive it works on the cough center to suppress the cough reflex. So GI irritation, dry mouth, constipation, these are common symptoms. Encourage fluid intake when you are taking all these medications. Avoid administration to the client using opioids, hypnotics, barbiturates, or select antidepressant because central nervous system depression can occur. Now, opioid antagonists, and this one reverses respiratory effect, depression on the opioid overdose. When there's an overdose, it suppresses that one. We know opioid is for pain. Now, the side effect is nausea, vomiting, tremors, and blah, 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 blah. For intravenous medication, the dose is titrated to 2 to 5 times, 5 minutes as prescribed. That's the opioid antagonist. So if the patient is taking opioid antagonist via IV line, let's say the patient took too much of narcotics and you want to give the patient Narcan. So the Narcan, you have to give the patient 2 to 5 minutes apart. So if, let's say I had a patient last week who came with opioid overdose, so I had to reverse it. So we had to give 0.4 Narcan now, and then we wait for 5 more minutes, the patient didn't come back. We repeated another dose of 0.4 Narcan. So in all, it's 0.8, and the patient got up. So you want then those opioid antidotes should function right away. So if it doesn't function right away, 2 to 5 minutes, you repeat another dose of it. Now, tuberculosis medication. I think this is, let me say, yeah, so tuberculosis medications, we all know that they put them on a regimen of treatment. I know some people always have a mnemonic for it. I didn't capture it because I'm not a big fan of mnemonics. I'm a big fan of understanding what it is. Even if I don't know more about it, knowing a picture of it, when I see the medication, I see rifampicin, I know isoniazid, I know it's tuberculosis medication. So I usually don't go into detail with mnemonics because I have a lot of songs to sing in my mind. Now I have this little tissue that I highlighted it red. I said active tuberculosis is treated with a combination of medications to avoid the organism that is susceptible. So it's a combination of treatment. We combine so many medications to be able to combat the organism that is causing the active tuberculosis. Now, individuals with active tuberculosis are treated for 6 to 9 months. However, clients with immunosuppression, HIV, are treated for a longer period of time. So I had mentioned that before. So 6 to 9 months is the standard period, but if they give you 6 to 12 months, it is allowed. So if the patient has immunosuppressed condition, the patient can go further after 9 months, which is up to 12 months. So mind you, we have susceptible infections that can set in when a patient has tuberculosis because your other body systems are weakened. So when you have other infections, then your treatment can go all the way to 12 months. But NCLEX will only question you. Most often, they want to know if you know the standard period. The standard will be 6 to 9 months for everybody. But if you have another infection that they think that your immunity is low, they extend it to 12 months. So I would pick 6 to 9 months when I have a question. If I don't have 6 to 9 months and I have 6 to 12 months, that is the correct one. After the infection, individuals has received medication for 2 to 3 weeks, the risk for transmission is greatly reduced. I think we spoke about this one already. So most clients have negative spirit cultures after 3 months of compliance with medication therapy. So if the treatment is 6 to 9 months and you comply with the medication, very good. In the next 3 months, your every 2 to 3 weeks, is it 2 to 4 weeks spirit culture will be negative after 3 months, but you still need to continue the medication for up to 6 months or 9 months. Okay, so even though after 3 months, when you comply with the medication, your spirit culture will start coming back negative. So every 4 weeks they do the spirit culture is negative until 9 months is up before you can stop taking the medication. You still need to follow the regimen. Individuals who have been exposed to active tuberculosis are treated with preventative isoniazid for 9 to 12 months. So these are people that have been exposed, like Clementina was asking. So if they want to give a prophylactic, then they will give you a prophylactic, which is isoniazid for 9 to 12 months. But that is just one pill of it. That's people who have been exposed. But even with that, if it comes to family education and the patient was in the house, we cannot put everybody on isoniazid for 9 months or for 12 months. That means everybody in the house is tuberculosis. You teach them to monitor their symptoms, and you teach them to also be precautious. When they start feeling the symptoms, let them come. Or if you can do immediate testing for skin testing, the exposure has been more than 2 to 3 weeks, then you do skin testing to confirm who is going to test positive. And you also want to ask them if they have taken the BCG vaccine. So the BCG vaccine will also come as a positive listing on the patient testing. Oops, my time is fast spent. I'm going to stop here. But I know we know the tuberculosis medications. I'm going to send this document if you guys will make time and go over it. I know it's a lot of reading, but you're not supposed to just understand everything. I want you to pick a general idea in all the topics. Pick a general idea of what you want to understand. And some of those words that are not familiar, those diagnoses that are not familiar, try to get them. And then when you get them, you work with them. Know where that name is coming from. NCLEX is not going to give you familiar names every time. They're going to give you names you are not familiar with. And that is it. Any question at this point?
No.
I'm a little down today because I have this cold, this cough. I was coughing so bad yesterday, so I wanted to postpone the class for today, but I realized the cough is better today. So I had some document that I wanted to discuss, but I'm not gonna do it. It's late, and I haven't been to my best today. I'm just trying, but I still have headache.
Oh, well.
Yeah. So Freddie, I'm also gonna send out this blood transfusion document. Then we try to go over it. You can just go over the tables alone. I know time is a problem here, but you can just go over the table alone. This one talks about the type of reaction, the causes, the symptoms the patient will have, and take note of the timing on every reaction. So NCLEX is going to present with you with a particular type of transfusion reaction. They will present with you the symptoms that occurred. They didn't occur 24 hours after the blood. They didn't occur within 12 hours after the blood administration. Then they want you to know. So you can go over the table and help with your blood transfusion questions too. It will be fine. I do have a couple of questions on that, but I didn't capture that. I wanted to talk about the NCLEX test plan, the detailed test reports that we usually get on the NCLEX. If you have ever written the NCLEX test before, or Clementina, the exam you have done before, mostly if they mark you, if they mark your submission, they are supposed to, they give you a detailed report of where you went wrong, what you answered that was wrong. So the detailed report on the NCLEX, I don't know who have it readily available, but I did have one. I don't know where it is. That was the thing I wanted to discuss with you people, because I have a whole lot of information covering only the detailed report you get if you don't pass the NCLEX. And the detailed report return back to you topics that the NCLEX want you to go and study. So in as much as we are trying to know content, you also need to dig into the detailed report. When you go into the detailed report, it tells you topics that you need to cover. So the next time I come, let's hope, I'm hoping that Monday I'll be much more in a good shape, even though I'm going to try to go into my cardiovascular and renal system are my two favorite systems that I always run with them so fast. But the detailed exam report is so much of a necessity to me. What's the date on Monday? Let me see the date for Monday. Huh?
23rd.
Third?
23rd.
Oh, 21st. Friday, would that be?
No,
23rd.
Oh, really? Friday, would that be late for you, or you have some more days? Because I wanted to go into the.
I can participate.
Correct. So I'm going to go into the detailed exam report on Monday. It come as topics. I will present it to you guys, and then we discuss it more. Even if we will not do the cardiovascular, we'll still go into the detailed exam report. I wanted to hit on that. When you have that detailed report in mind and you understand the topic NCLEX wants you to cover, it actually directs you to where to learn. So once you have your content in the background of your mind, the detailed report guide you as to which area you should specifically be well abreast in the NCLEX. So I think I'm going to try to jump into the detailed report on the next day we meet. Okay?
Okay.
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 Yeah. Any question at this point?
No.
Nothing?
Thank you.
Freddie, how do you see the questions, the 75 questions? A lot of calculations.
They are standard questions.
I know, they're not cheap.
Very good questions. Sometimes I struggle to select one of the answers.
Simone, what do you
think? You have to think about them.
Yeah. They're standard questions.
I can't just use 2 hours to finish. Sometimes it goes beyond 2 hours.
But you know, once you do that, you have to be timing yourself. Last year, those who took the NCLEX, they were lucky that because of the COVID, they had cut a lot of places and they were in need of nurses. I knew somebody who had done the LPN and she was contemplating whether to take it. I told her to go ahead because that was an opportunity. They passed a lot of people last year. They passed so many people last year on the NCLEX. The little effort you made, they passed you. Another fallacy people have in mind is that if I write the NCLEX for Florida, it is cheaper than New York. It's a lie. It's never cheaper. It's a standard national exam. So people have this in mind. So you see nurses graduate from nursing in New York and they go and register for another state because they were told that state, their exam is cheaper. It's not true. It's the same thing. It's just not true. It's the same nursing content we all need to know. It's the same trick, the same strategy they use. So it covers everywhere. When you are doing the Nurses Association, it's a general body that governs the whole American nurses. So it's not only a group. So don't be deceived by that one. Just study and know your content. Those questions were standard, I know. But I wanted to see how you play it. So mind the time. The timing for the exam, usually I think it's 3 hours, right? If I'm not mistaken. Is it 3 or 6 hours? I forgot the time now.
It's 5 hours.
It's 5 hours for LPN or RN.
300 minutes, which is 5 hours.
Okay. So imagine if you have that time and you're able to go only 75 in 2 hours. That's a little slow. Some people finish the 75. Some people finish the 75 in 30 minutes. But I know I cannot because I'm the type that take my time. So try to speed it up yourself. When you are going to test, put the clock down, or you can use your phone. Put 75 minutes. Don't review in a book and try to make it like a test. You are testing yourself to see how I would have been behaving if this was a real NCLEX. So you put the timer down, you put it for 3 hours, and then you are testing yourself to see how much time you spend on that 75 questions. If you are spending more than 2 hours, at least that's too much time. You know 75 questions, you have 265 to answer, then you want to limit yourself. I don't know, last year they had reduced the questions. I'm still tracking their website to see if they have reduced the number of questions they now offer to staff. But last year there was a reduction, but that reduction was for the period for the COVID. So I know they went back to normal because they are trying to start another test plan next year. So every year, every 4 years, they make changes to the test plan. But that doesn't affect your studies. It doesn't affect anything. If I'm learning for a test plan today, and they come to say they change it for next month, it doesn't change anything. They will just tell you they are making updates to it, and most of the updates, the next update they'll be thinking about maybe COVID, and we already have SARS in our respiratory system before COVID came. So it's not going to make any new differences. I also have some TB medications somewhere in my documents. Remind me if I forget, I'll just run over them. I'll mention them to you and have you have them at the fingertips. Once we keep learning new medications that are coming up, they like to dig into those ones when they see it's making a public impact. NCLEX like to twist people's mind, because when you keep seeing it on the TV, most of them you haven't seen them in the classified form of that medication yet. So they like to question people on that, because they pick people on the street or people that come to the hospitals to ask the questions. So they'll present those questions to you. Any other thing to talk about?
I noticed in the quiz that you sent us, there's a lot of calculations.
Yes. Any good news with that?
Any good news?
With the calculation? Is it too cheap? Too cheap, right? Are the calculations too easy for you?
No.
It's to twist your mind. It's to have you think broad about the NCLEX. It's to have you think broad. Huh?
The calculations were very difficult for me.
I can't hear you.
So the calculations were not difficult.
They were not difficult. That is good. NCLEX, yes. The pharmacology is not usually difficult. If you ask me, I'll tell you that. If you sit on the NCLEX, it doesn't matter if you are passing or you are failing. Most of the NCLEX calculations are not difficult questions. They are straightforward. Like I told you, under pharmacology, NCLEX pharmacology is a straightforward topic. They cannot pick a nausea and vomiting medication and they expect that one to be for fluid retention medication. No, they go straight to the system. Those medications, the questions are usually straightforward. They want you to just know if there's anything specific to note when I'm giving this medication. If I need to know that the patient is taking grapes and should not take this medication. If I know the patient is taking cranberry juice and should not take this medication. If the patient tells you my urine turned yellow, my urine look bloody when I take this medication, my skin look like I have jaundice after I started taking this tuberculosis medication. Those are the things NCLEX want, they will twist your mind about. But besides that, pharmacology is always straightforward. And calculations, they don't give you too much calculations like this one I gave you. But this is just for practice, but they are standard questions. Any of them is possible. And mind you, NCLEX questions are circulating all over. I haven't seen anybody tell me this is question straight from NCBSN. But I tell you, most of the questions you will meet in your studies, when you get to the exam room, you will see similar questions with changes. Yeah. You will see similar questions, but they will change the question. They will twist it out. So they know people have questions to ask, but they twist it. They change everything. And me and you sitting in that exam, we will not be writing the same questions. You'll be sitting next to me. We are both writing RN exam. We are both writing LPN, and we are writing different exams. So that's why it's never a predictable quiz, because they have a dozen of a website that gives them a question bank that they keep pushing the questions to students, and they select it based on how you are doing. So that's it. That's pretty much it. But the pharmacology, I want you to do a lot of calculations. Let me see how much we do calculation when you get to the floor as a new nurse. Okay, Simone. Any question? Anything to add? Any question? Or we are done for the day? Are we good?
Yeah.
Okay. If you have any question within the week, like, I mean, it's really not this week. I'm just out of it. I'm on vacation, but I don't feel well. I don't know what happened. I took my vacation with a lot of plans, and my baby catch cold in the house, and now they are even better than me now because they are all fine. It's just me. But today I'm fine. I have just a little headache, but I think I'm out of it. Tomorrow I should be stronger. So I'll put down a lot of things for next Monday when we discuss the test plan and the topics to cover under that. Okay.
Okay.
Right.
So when you finish the exam, you can just send it back to me. You can email it. This Google is giving me a different thinking. Yeah. Okay. Thank you so much for coming and have a good night.
You too. Feel better.
You too. Feel
Thank you so much.